So thanks for having me. I must admit I was a little anxious about this talk. This is definitely a different audience for me to speak to. Usually everything is within the medical school or the hospital. So it's nice to be able to shift gears every once in a while and talk to new groups. I think it kind of keeps you honest with how you give your talks. So by way of introduction, so it says a couple interesting things. So full disclosure, so I'm Catholic, so if I was going to go to the ice cream cone, I probably wouldn't have one because I just feel guilty that I was going to be gaining weight, so I don't have anything. And then if y'all think that we got it down pat in healthcare, I hope that can, I really hope that that's not the case. Because if we're doing it the best, then we're all in trouble. Because I don't think we've got this down pat yet with regards to medical education. We've been doing it for a long time. And I hope to share with you some of the things that we're doing now. There's been a lot of change in medical education over the past 15 years. It's much more structured than it used to be. So I think that there's some lessons that we've learned, and hopefully I can share some of those with you. I'm from Chicagoland. I'm local. I went to St. Xavier College. I went to Loyola then for medical school, and I've been there ever since. 2 kids, 15-year-old daughter who's driving me around now, which is kind of weird, and an 11-year-old son. So, and my wife and I have been married 19 years. She's also a physician over at Loyola. We didn't meet at medical school. We met when I was delivering pizzas and she was working at a gas station. So that's kind of how we met. Like we said, I've been at Loyola for a while. I did my medical training there. I did chief residency there for both internal medicine and pediatrics. I'm boarded for both internal medicine and also for pediatrics. I was then the program director there for 15 years, from 1999 to 2014. So as a program director, what that means is I'm in charge of recruiting for and then training my residents. So I had 4 residents per year that I would get. So I had 16 total in my program. And residency programs vary in size. From some programs might have 5 residents or trainees in their program, and some might have as many as 110 residents in their program. So it just depends on the discipline. Last year, I decided that I was going to step down from being program director because I figured I'd done it for 15 years and it was time to let somebody else do it. And then in stepping down from it, they asked if I would help out in a different area. So it wasn't my plan to go into graduate medical education. It just sort of ended up there. So here we are. So Loyola Medical Center, just as by way to orient you a little bit, Loyola Medical Center and Loyola University have a relationship. The Loyola Medical School is still part of the Loyola University. The Medical Center, though, is separate from the university, although we're on the same campus. We have different books and everything else, and this happened a few years ago when all the Jesuit institutions in the country, Georgetown, Creighton, Boston, they split with the universities, largely because of the negative effect of healthcare on bond ratings at universities. So that's kind of where the financial schism happened from that. The medical school, though, is still very integral with what we do. We still train the medical students in their clerkships, and we're still lecture all the time at their medical schools. So we're very involved with the medical school per se. We have 65 residency programs and about 650 residents that I'm in charge of now with the GME job. We have 750 attending physicians in our hospital. We have a 560 roughly bed hospital that is Loyola. We're a level 1 trauma center. We have medical school and dental schools there, so we interact with the medical students from both the medical school and the dental and the nursing schools. We are a referring hospital. We see patients and have clinics down as far as Peoria and Rockford and stuff like that. So we have patients kind of all throughout Illinois. And we have a very diverse patient population, which I think is probably one of the biggest strengths of Loyola. And we kind of talked a little bit what keeps, what the institution brings to its trainees. And I think one of the best things that our institution brings to our trainees is the diversity that we have of our patient population. We have everything from very affluent to undocumented and everything in between, and every language and every culture in between. So it's a wonderful opportunity to do your training there. You really get good at talking to people, I think, the way you're supposed to talk to people. And we're kind of working with everybody the same way. We don't have separate services. There are teaching hospitals that will have a separate insurance and then non-insurance services. That doesn't happen at Loyola. So I've been very blessed to be part of that institution for my career. So what I'd hope to do for you today is talk a little bit about the formative process involved in resident education, to talk about some of the newer things that have happened in medical education involving competencies and milestones, and I'll explain what those are in a few minutes. Talk about the evaluation in physician training and why we do things the way we do when we evaluate them. Talk about some challenges that we've discovered about that. And if we have time, go through some of the lessons learned with regards to teaching the educators of how to work in the new system that we have now. So just to kind of go through medical education with y'all real quick here. So when you're in college, to start with college, and then you go to medical school. Medical school is 4 years long. Residency, it depends what you go into, but it can be anywhere between 3 and 7 years. Fellowship, if you choose to do a fellowship afterwards, can go on, and then you become an attending physician. So to talk a little bit about this, so medical school, you have 4 years of medical school. Your first 2 years are your preclinical years, so you do basically textbook stuff. So you sit and you read a lot, and then you take some boards, and then you go into your 3rd and 4th year. In your 3rd and 4th year, you do your clerkships. So you rotate 6 weeks in different rotations, so OB, internal medicine, pediatrics, neurology, surgery, those type of things. And then you graduate from medical school and enter residency. And I always tell the medical students that after medical school, you're really only trained to sit in one place for a long period of time and study. So what you could really do at this point with your training is you could be a doorstop or a paperweight, but you really don't have any clinical skills that help you go out and practice. And unfortunately, at this point, you're 55,000 times 4 in debt. So medical school is about 55,000 a year for medical school. So you're really not trained to do anything. Then you enter a residency. So it's an apprenticeship, truly as I think probably one of the oldest ones, although the video this morning probably shows me that it's probably not one of the oldest ones. It's 4,000 years in the making for teaching priests or clergy. But it's pretty regulated. So a couple more definitions to go through. PGY is postgraduate year, so that's after medical school. So if I refer to things as like PGY1, PGY4, that's how many years they've been out of medical school. Residency is your PGY 1 through 7 years, and basically the person's an MD, but they're training to learn how to be whatever specialist they want to be. Your intern year is your first year of your residency. I don't know why it started that way, but it's always been called intern year as your first year of residency. Fellows are people who've finished residency, but now they're going for extra training beyond that. And then an attending physician is someone who's licensed and can practice on their own. So back to residency training. So like I said, you've got first year is your intern year, you've got between 1 and 7 years, and when you're done, you could practice the general specialties. So internal medicine, pediatrics, psych, neurology, pathology, those type of things. If you choose to enter a fellowship afterwards, it depends how long it is, but between 1 and 3 years, and that's where someone becomes like a pulmonologist or a cardiologist or an interventional cardiologist, orthopedic surgeons, orthopedic hand surgeons, those type of things. And then you take your boards and you get a real job. So after all that time, you finally finish and you can finally go out and get a real job. So what's GME? So graduate medical education is what it stands for. We have an accrediting body, and that's the Accrediting Council for Graduate Medical Education. And those are basically our rule keepers. And those are the ones that tell us what all of our trainees have to do in their individual specialties to go on and be able to complete and practice independently. We're also responsible for the education and the well-being of our residents. So if there's bad behavior, if there's discipline issues, it comes to us. So in the hospital, and largely like probably what you guys do a lot, you guys all wear a lot of hats, so you end up doing lots of different things. So within GME, we have a lot of roles that we have to interact with and work with, and sometimes be the interference between two different groups. So hospital administration, the nursing staff, the ACGME, the residents, security, human resources, we end up working with all these things. And like y'all, in any given day, you can be any one of these things probably multiple times throughout your day. Sometimes you're a hero, sometimes you're a villain, sometimes you're a scapegoat, sometimes you're an arbitrator, sometimes you're the person who solves the problem, sometimes they feel you're the one who makes the problems. So you end up going through a lot of these things throughout the course of your day. But what's nice about Loyola and being rooted in a Jesuit is we really get an opportunity to really train something that's very important to me is our focus is our service and education. So we really train people to be good educators. There's a big focus at Loyola Medical Center about teaching people to educate, not only themselves, but their patients, but also their trainees. But the service aspect is important in that we care for others. We have a very big service mission at Loyola, working with local pad shelters, we're working with Catholic Charity Organization in Chicago, and just in general local homeless shelters as well, and a large, like I said, large underserved and undocumented population that we're part of as well. So I really am fortunate to have been part of this for the past 25 years. How do we train people? We train them with direct observation, we train them with simulation, we train them with lectures, those still exist from the first few years and even during residency. We talk about skill demonstrations, they have to take their board, so they have to get knowledge from that. And then also we train them with some of the principles of Magis, and that's Ignatian mentality. But The Ignatian mentality of Magis is really sort of the embodiment of saying, given all the choices that I have right now of what I could do, what's the best that fits in line with what my calling is as a healer, and the best in my lines of, that is akin to my spirituality. Caring for the whole person, that implies not only for the patient and the other people they come into contact throughout the day, social workers, nurses, but also with themselves, making sure that there's some self-care involved in what they're going through. Being contemplative in action, making sure that they think of things sort of for the greater glory of God in what we're doing, try to be the best we can be. And the last one is really just making sure that we keep a big focus on service and why we do things. I'm convinced that one of the big things that we do with training is we get people involved in service projects, because the more involved you are in those things, the deeper that well is. So every time you're feeling tapped and drawn and you don't got anything more to give, you do some service projects, and it's amazing how that well always stays, at least with something in the bottom of it you can pull from if you need to. So really, I'm sorry if you're not a Hawks fan. Well, I'm not really. We really have a goal in GME, and that really helps when it comes to working with all the other organizations that we're part of. And our goal is really to make better physicians, to make the best programs we can that are within the Jesuit philosophy. So how do we make a good doctor? So this is an interesting idea. This was how we used to practice. And this said, if musicians learn to play instruments as physicians learn to interview patients, the procedure would consist of presenting in lectures or in demonstration the theory and mechanisms of the music-producing instrument and the ability of the instrument, and then we'd tell the learner to play. The instructor, of course, would not be present to observe or listen to the student's efforts, but would be satisfied with the student's subsequent verbal report of what came out of the instrument. And that's how we used to do it. We would teach the medical students, we would teach the residents about what to do, and then we'd say, go do it. And they'd come back and tell us what they got, and we'd say, okay, that sounds reasonable, that sounds like a good plan. But there wasn't much of an interface there in between that. So that's where the ACGME stepped in a couple of years ago and came up with some new concepts. So prior to 2002, these didn't exist, and then they came up with the concepts of competencies and milestones. So we have 6 core competencies that all doctors are supposed to be able to do or demonstrate proficiency in. Patient care, practice-based learning, systems-based practice, medical knowledge, professionalism, and communication. System-based practice is how well you work with other people in your healthcare system, so the nurses, the social workers, the other physicians, and practice-based learning is how well do you work on your own medical knowledge to advance that as you go from one year of training to another. How are you making yourself a better doctor? What sort of self-improvement plans have you come up with? And then, obviously, technical expertise for those who are surgical-based professions. So we also have lots of evaluations that our trainees get. So we have what are called 360 evaluations that happen throughout the course of any given rotation that they do. So if an internal medicine residency is doing a hematology rotation for the month, they'll get evaluated by all the nurses that they work with, the social workers, the medical students, their trainees, and all those will come to the program director to filter through the information that they get. We also give them in-training exams every year to find out how their medical knowledge is progressing from year to year. And we go through quarterly milestone assessments. And I'm going to talk about milestones next to help understand a little bit how they work, and maybe it's something that you guys could utilize as well. So the clinical 6 competencies then spawn milestones. So within our individual disciplines, the 6 competencies are the base, but then what comes off of those are the milestones. So for internal medicine, for instance, we have 21 milestones. For pediatrics, we have 23. For surgery, we have 25. So we have different milestones that they have to do. And this is very small, and I apologize for the slide being small, but I want to read a little bit from this slide. Miles are knowledge, skills, attitudes, and other attributes for each of the ACGME competencies that describe the development of competency from an early learner up to and beyond the expected levels for unsupervised practice. So we take the milestones and we grade them as they go from year to year to year and see if they're improving on how we'd like to see them develop new competencies. Milestones are arranged in columns for progressive states for competency that do not correspond with postgraduate year of training. In other words, we like to assume that a PGY1 is supposed to do one thing, and a PGY2 is supposed to do another thing, and a PGY3 is supposed to do a third thing. But it doesn't necessarily, those lines get blurred. They're not exactly as clear as that. Some people might attain competencies before the end of a PGY year. Some people may take longer to get those competencies. There are critical deficiencies that are level 1s or 0s, depending on whose competencies you're looking at. And then they move across all the way to level 5. And level 5 is aspirational. And what aspirational is supposed to be is, if I'm really good, at some point in my career, I might achieve a part of that aspirational person. So like the stuff that you read on the aspirational levels are just ridiculously glorious phrases of how someone who is doing medicine absolutely perfectly would be practicing medicine every single day of their lives. Most humans practice somewhere in the 3 and 4 level that they have, but there are some of our trainees that we get that are just outstanding in certain areas, and that's why the 5 category was created. So we have a bunch of milestones that look kind of like this. So like I said, for medicine we have 22. And there's a checkbox along the bottom of each one of these. So this is 0, 0.5, 1, 1.5, 2, 2.5, 3, 3.5, all the way up to 5. We have critical deficiencies, level 1, 2, 3, and then aspirational. And again, the aspirational are the ones that are really, really good and you look up to for how they do things. So for those who can't read in the back, critical deficiency for patient care. Cannot advance beyond the need for direct supervision and delivery of patient care. Cannot manage patients who require urgent or emergent care. And does not assume responsibility for patients managing decisions. So that would be like a level 1 milestone. There are some milestones that some of the disciplines have that if you end up over here, you probably should be arrested and never asked to be seeing a patient again. So these aren't quite as dire as those. And then as you go across, so the top one requires direct supervision to ensure patient safety and adequate care. So that's a PGY1, that's an intern. The job of an intern is we're supposed to supervise them so they can, and observe them in doing their patient care to make sure they're doing patient care well. They're not allowed to practice on their own. Next one requires indirect supervision to ensure patient care and quality of care. So they don't need supervision every moment. You can see, they can come to you, tell you what they want to do. You can go see the patient and go, yeah, I agree, that makes sense. And you can have them do those things. That's a level 2. Level 3 independently manages, level 4, independently manages patients across inpatient and outpatient settings who have a broad spectrum of clinical disorders, including undifferentiated syndrome. So that's a level 4. That's someone who's ready for clinical practice. They can go see anyone. They can walk into a room. They can put together the knowledge of what's going on with that patient after interviewing them and doing their exam, and they're ready to go out and practice on their own. And then there's level 5 that they can manage anything that they've ever, obscure possible thing that exists. So very few people are level 5s. House, maybe a level 5. If you want. Another example of patient care milestones I think is interesting. So with regards to gather and synthesize essential and accurate information to define a clinical problem. So this is patient care 1 milestone. So does not collect accurate historical data, inconsistently collects historical data, consistently collects it, acquires accurate histories from patients in an efficient, prioritized, and hypothesis-driven fashion, and then obtains relevant historical subtleties, including sensitive information that informs a differential diagnosis. So you can imagine if these evaluations are filled out on someone's patient care skills 36 times in a 3-year residency program, you're going to see some progression, hopefully, as they move across those 36 months over to the right a little bit. We have things for practice-based learning, and I put up an example on here because it's a hard thing to get your head around. So practice-based learning disregards your own clinical performance data and demonstrates no inclination to participate or even consider the results of quality improvement efforts. Again, might be put in jail for this type of stuff. Versus actively monitors clinical performance, is able to lead quality improvement projects, and utilizes common principles and techniques of quality improvement to continuously improve a care for a panel of patients. And if you're bored one day and you want to look up ACGME milestones, these are all online. You can find these at any discipline you want to online for the ACG milestones projects, and it might give you some ideas of how we look at things. Professionalism, I think, is an interesting one to see whether or not we deem someone to be a professional as they go through their training. So you can look at the left, blatantly disregards formal policies or procedures, does not adhere to basic ethical principles. Again, put them on an island and never let them see another person for the rest of their lives. Refuses to account for personal actions, versus role models integrity, honesty, accountability for all professional conduct in all aspects of professional life. So that moves across throughout their training. You all familiar with the Likert scales? No. Likert scales basically give you a 1 through 5 or a 1 to 9 or a 1 to 7. And they basically have very disappointed to extremely satisfied type things, and then everything in between that. And back when I trained, that's all we really had were these Likert scales, and everyone was off on the right. As a matter of fact, if you didn't have straight 9s in your evaluations, you got worried about it. And the medical students, being the higher achievers that they think they are, they always want 9s. You could never tell a medical student that they were average in what they did, because then you got to argue about why they're average. So what's nice about, and not everyone's above average. It's hard for everyone to be above average. So you have to kind of go back and explain that. So what's nice about the milestones is it moved us away from checking that box to very satisfied, or to always, or that everyone gets the smiley face type thing. So it gets away from that mentality, and it shows actual definable things that help us figure out where somebody is in the course of their training, and more importantly, shows us where there's deficiencies. So if someone's not achieving those levels like we would expect them to, we'd like to know why and figure out how to help them that. So ideally, what a milestone should do is it should promote a competency-based resident education. It should allow programs to track the progress of their residents, to inform decisions regarding promotion or readiness for independent practice. It should guide curriculum development. It should suggest specific assessment strategies, provide benchmarks for residents looking for self-directed activities, assist remediation, and improve public accountability. Back to that, I'm sorry. Okay. So again, what it does that the Likert scale ones didn't is it really showed us, number one, how to assess when someone wasn't doing well. It actually helped us understand in what area and how we could help them with that. Number two, it provided us with an opportunity to give them feedback that was much more relevant, rather than you're not doing a good job. We can say you're not doing a good job in this, or we need improvement in this to help you get better. And so that was a very useful thing for the Milestone Project to give us. It also helped us with regards to promotion. So if someone wasn't quite ready to be a senior resident, so a senior resident means that you're supervising a more junior resident. Maybe we all kind of watch them and like, you know what, they kind of get it, but they're missing stuff. I'm not sure they're ready to do that. We look back and see what their competency milestones have been, and we say, yeah, you know what, other people have felt this too. They're not quite at that level. They don't synthesize the data the way that we'd like them to. They're not ready to lead just yet. Let's keep them from that promotion just yet and give them a couple more months and then reassess them and see how they've done on that. Can it prohibit someone from graduating? Maybe. We'll talk about that in a little bit. So as you create milestones for your own groups, the first thing you need to do is figure out which specific competencies you think someone needs to have in your profession to be qualified to be a practicing whatever, a practicing pastor, or a practicing anything that uses milestones. And then you have to work backward to find out at what point do you think they should achieve those milestones. So should it be 3 months into it? Should it be 5 months into it? Should it be a year and a half into it? When do you think that they should be able to get to those things? And the last one is decide what the prior and subsequent skills should look like. So right before they're able to effectively get an interview or effectively synthesize information that a patient has given them, what does that look like? That they intermittently synthesize it? That sometimes they miss big points? What does that look like in words that you then can go back to your trainee and say, you know, you almost got it, you're getting there, but I've noticed that sometimes you don't quite get all the information you need to, or you jump to a conclusion before waiting and hearing out the rest of the information, or maybe next time consider this as a diagnosis for what might be wrong with that patient as well, before you jump to a treatment plan and ignore the other clues that might be going on. So that's how milestones are created. How they're evaluated in our programs are something called the Clinical Competency Committees, or our CCCs. So the Clinical Competencies Committees meet, we have to go through each trainee twice a year. And we break our trainees down into PGY levels. So like we meet with all the PGY 1s twice a year, PGY 2s twice a year, PGY 3s twice a year, and that's 6 months. So every other month we meet, depending on which group I'm involved in those committees. And we go through each resident. And you sit in a room with a bunch of people who are also doctors, who have a stack of files in front of them, and each one of those docs is assigned a group of residents. And they go through all of their evaluations and all their milestones and see how they've been performing on that. And you go around the room then and you present your residents to the whole group. So we meet twice a year for each trainee. Ideally, a CCC should have 3 people in it. Those are the rules that we have for it. Monthly scores are averaged. Comments are then also reviewed by the group. So like I said, those 360 evaluations that happen, the comments that come out are talked about in the group to look for any patterns that come in. Non-milestone assessments also looked at. So are they attending the conferences? What are their in-training exam scores looking like? How are their written evaluations, or what are the comments coming back from them? The program director is involved, but the program director is not chair of the CCC. So that's an interesting stipulation that in the wisdom of the ACGMI get what they wanted. So the program director is supposed to be the advocate for the resident. You're there to make sure that your resident gets a good experience, that they're educated. You're also there to help your resident when they're having problems, personal problems, emotional problems, those type of things. So if they're struggling and they're using you as their confidant, it's hard for you then to make the decision whether or not you're allowing promotion or not for somebody. So you can be part of that committee, but your job is not to be the person who overall chairs that committee. At the end of the meeting, or at the end of that evaluation, we provide sort of a consensus statement with where that trainee is. We advise the program director whether or not we think that they're progressing appropriately, whether or not we think they need remediation, or do they need dismissal. The program director or the advisor then meets with the individual trainee to go through what the recommendations of the CCC are. And we have to submit these twice a year to the ACGME to show them how our competencies are evolving. The ACGME, the big governing body, then looks at all of these, looks at our programs, sees what our board's pass rates are, see how we're doing on our surveys that they give out each year to all of our training programs, and then really decide whether or not the programs are competent or not. Are they training physicians appropriately? So the overseers look at the data and then periodically come and do site visits to us and make sure that we're doing things appropriately. So what you get, if it's done right, is this is one of our residents, and the bottom here, December 2014, June 2015, and December 2015. And you can see that if you plot this out of where they are, so this is professionalism, interpersonal communication, patient care, medical knowledge, systems-based practice, and practice-based learning, and all the different sub-competencies and milestones that come from it. And you can see that as you plot those people out throughout the course of their time, you should see a progression outward on that spider web. You should see then that they move from a level 1 to a level 2 to a level 3. And what's nice is if someone's not progressing, like maybe they have a divot right here in practice-based learning 1, you can go back and look at what that practice-based learning 1 is looking to assess, and then you can go back and talk to them and find out why are they not reaching those milestones like they were reaching the other ones. For some people, they look like wonderful tires. For some people, they look like horrible divots and pies and like things cut out of them and stuff like that. And those are the ones that you have to go through and find out what's going on. Why is their medical knowledge lacking? Why is their patient care abilities not where they should be? And why is it not progressing? But it really gives you tangible things to show them where they are in their development for their milestones. A couple loopholes real quick. Can a trainee achieve advancement by failing to achieve a milestone? In other words, can you not graduate on time if you're not a level 3 or a level 4, which you should be ready for independent practice? And the answer is yes, you can hold off somebody from graduating if they haven't reached their milestones. The caveat that, though, is the length of training may need to be extended to compensate for that, but there's no funding there for that. So the institution ends up eating the funding for it. If you go into internal medicine, you're funded for 3 years. If you go into pediatrics, you're funded for 3 years. If you go into surgery, you're funded for 5 years. If it takes longer than that to achieve that, the institution ends up eating the price to train those physicians longer. Now you might say, well, what if you reach a level 5 before your 3-year or 4-year or 5-year training? Can you graduate early? No, the ACGME is clear on that one. You can't graduate early. So you're just a really good resident, but you're not allowed to graduate early. So I've got a couple other things that I was going to go through with regards to some teaching, but I know I went through that a little bit quickly because I deal with that every day. But does anyone have any questions on the milestones or how they're developed, or want me to go back to a slide to show something that I went through quickly?
Question. As we're trying to apply that to this, obviously everybody's signed up for this whole program, or they wouldn't be in medical school, right? I mean, so they
You don't have a choice.
Right. And so is this driven as much by external legal defensiveness, or I'm trying to get over to us as clergy, which clergy negligence and malpractice is a growing part of the law. But you just want to have a great physician, and I'm trying to figure, how do we get our people to agree to go through, I mean, I can't imagine any pastor going through this regimen of a system in seminary, but does that make sense?
Yeah. So why, I guess if I to paraphrase it, what's the why did we all buy into it, and what's the purpose of having a standardization like that? Is that kind of the question?
Yeah. And how did they come? And obviously, Walt just said they used to have the list thing, and now they have the milestone thing.
Yeah.
Which works better.
So back in the day, so back in the 90s and prior, so it was a little bit of Wild West type thing in medical training. The attendings might not even be involved in a surgery that the residents were doing. They might be in the same building, but they weren't actually scrubbed into the case, right? So Wild West, right? And that was rare, but it happened. But then the Libby Zion case happened in New York. I don't know if you guys were familiar with that, but she was the daughter of a senator, if I remember the story right, who had been treated by a resident physician who was felt to have been up too long and was felt to have been given the wrong dose of a fluid and ended up dying because of it. So medical education really went under the spotlight at that point, under the microscope at that point. And the Institute of Medicine went through and evaluated the training process and really changed around supervision. The focus on supervision really needed to be there. Now, my residency training program, I never had that type of issue where the attendings weren't around, and we really didn't really have that at our institution either, but there's stories of these things happening. And that was the start of it. So right around 2000, 2003, duty hours started coming out. They started focusing on making sure that there was better supervision and duty hours. And at the same time, they realized that if we were having physicians being sanctioned by a governing body, the ACGME, then the ACGME really needed to have more hoops, I guess, that the individual programs, or standardization, I guess, of the product that were being created at the individual hospitals. And what proof did we have at the individual hospitals that what we were doing actually made competent physicians? So then they came up with their competencies, and then after that, how to achieve those competencies through the milestones. Does that make sense? Okay.
I'm still thinking about your opening slide where you gave some numbers, and what I'm wondering is parallel to the church, whether it's possible to train the number of interns relative to the number of clergy. You said, if I wrote it down right, you have 750 physicians, 640 trainees.
So 650 trainees and 750 attending physicians.
Okay, so that's almost a one-on-one ratio.
Yeah.
In a setting of a 529-bed hospital, and all broken down into 65 residency programs. So, am I hearing you that there's almost like one physician for each one training? And so, the analogy I'm wondering in the church is if there are 3 on staff of the church, could they do 3 residents?
Would there be enough things for them to do at the individual church?
Assuming yes, there's
Yeah.
plenty of
So sure.
need and need
Yeah.
for leadership development, outreach.
You certainly could have that. The danger of having a one-on-one, though, I think it's nice to have more people doing evaluation. So I think if you had one person just evaluating one trainee, and it was like that in 3 different spots, depending on that evaluator's skills or feedback abilities or teaching abilities, you might have very disparate outcomes from the trainees who are working with them.
What's the function and maybe the philosophy behind a competency-based model that still has timelines attached to levels of competency, and even still a requirement of particular input of time and how long you're in a residency? Like, what's the philosophy?
Why?
behind that tension?
Old school, new school.
Yeah.
Old school has the money, and that they pay for 3 years. And then new school trying to figure out what they're going to do with that information. So we just had an example of this in our training program this year. We had a first-year resident who was really great, and she's fabulous. And we said, we're in a little bit of a spot. We have a gap in our schedule. Could we have this first-year resident be the senior resident for one of the other first-year residents who's not progressing as quickly as her later on in the year? And the answer to that was no, you can't. You can't have a PGY1 resident supervising a PGY1 resident, no matter how good they are. Just like I said at the end, if someone's doing really that well, can you graduate them early? No, because you still have to, for the boards, you still have to pass 36 months of training for internal medicine, or 36 months for pediatrics, or 60 months for surgery. That's still set in stone. So that may catch up with milestone training over time. I think people are still waiting to let their breath out to see if it's working. And I'll share some information with you. There was we had been leaked some information by the ACGME last year at a GME summit in Chicago to show some of the preliminary data. And what they had said was if, they showed us a certain number of programs, and they showed us that there was a percentage in those programs that hadn't reached level 4 by the time they had graduated. So they had finished their time, but they weren't at a level 4 in a couple of these things. And we said, okay, so you can't release that information because all you're going to say at that point is that residency programs are turning out physicians who are not capable of practicing medicine, right? Because they created up the standards by which all of a sudden that we had to gauge these things. And so what we have to do then is go back to our program directors and our evaluators and figure out more how are we using this tool. And the tool is still imperfect. So this is still a big growing process with the milestones. I think it's a step in the right direction. As much as I didn't want to like this idea, I really do because it really does help us focus our training and how to get them to think a certain way or find where the deficits are in people. But you're right, that time frame and milestone numbers are still a little disparate.
So if you're going from the Likert scale to this web and the competency idea, I have to believe that is a lot more labor intensive than checking the box.
Yeah.
And did you learn anything as you took physicians who I imagine are already pretty busy and increased what they had to do in order to provide feedback? How did you win them to that idea, or were you able just to mandate it and that's just how it is?
Well, a little bit, yes, to the last part, because it's the ACGME that told us we had to do it this way. But I think that anyone who had been in practice and evaluating trainees for a while realized that the arbitrary nature of the Likert scale really didn't help you figure out how to help somebody. All it did was a pat on the head at the end of a rotation, but you didn't really get any feedback to how to get better. Whereas the milestones shows you a tangible outcome that you want to achieve to reach that next level. Also, it's shifted everyone's thinking around because a resident looks at these scores now, and even though they're used to the old ways back in medical school of everyone getting a 5, now they look at it and say, I don't know anyone who's a 5. Like I hope one day to maybe be part of a 5. Right now, yeah, I'm doing right where I'm supposed to be doing is 3. And it showed people really more of it shifted the curve back over to the middle and said that average is there for a reason. Like average doesn't mean bad. Like it's good. Like everyone's progressing at different steps, but hopefully by the end of your first year, second year, third year, you should be reaching those levels. So there was a learning curve for the attendings who had been used to doing it the old way. And simplifying the tools was very important. So at the end of a rotation, to give an attending 23 different milestones to fill out and an individual trainee was way too labor intensive. So then we went back and we said, okay, so when they're doing the ICU, what are the things we want to be able, they should be able to demonstrate? They should be able to interpret an EKG. They should be able to evaluate a chest x-ray. They should be able to have an end-of-life discussion with the family. And these are the things that in the ICU are unique to the ICU for those milestones. And so maybe in the ICU, they just fill out 6 of the milestones that are unique to the ICU type situation. On a floor rotation or an outpatient rotation, they may have more interaction with nursing staff or social workers. And maybe that's the one you want to focus on, interpersonal communication, and see how they work there or within the systems-based practice type milestones. So the milestones can be chosen for different rotations that the residents are taking. And it helps the attendings better evaluate them. So it is labor intensive, but people bought into it once they realized that it helped provide more concrete feedback. Yeah.
It seems, if I understand it correctly, that you basically do a lot of book learning and then a lot of hands-on stuff. And is there much interplay of that, or is it very separate?
So the book learning is very much in the medical student 1 and 2 year. The book learning is rotation specific for your 3 and 4 year during medical school. Once you're done with medical school, though, the learning that you do is very much around patients or around rotations you're doing. So if you're on a gastroenterology rotation, you're reading about gastroenterology all month. You're reading the newer articles or the landmark studies that came out, and that's what you're reading for those patient care things. So, but it's much more clinical oriented once you get done with medical school. So and the medical schools are starting to adopt the competencies now as well, but it's more stubborn for it to leak into the medical school world right now. But the residency stuff is sort of leading that. So there still is some reading, there's still some book learning when you're done, but it's much more practical, hands-on stuff when you're a resident. So I guess I would liken that to someone coming out of school for a theology degree and then actually going into one of your parishes to work. And then what do you do with them in that period of time, right? Someone else had a question? Or yes?
Does the back end of the pipeline in terms of demand in the market by going to residency give them more opportunities in the marketplace by having this kind of seal of approval of their competency level?
No. I think ultimately it doesn't change the public perception of it. I think why the ACGME did it was to get out in front of that and said we want to be able to prove that what we're graduating are competent physicians. So I think before they got dinged with not producing competent physicians, they wanted to show that they were producing competent physicians. I think that's how it went. But you're right, there is no, you get a better job because you scored this way. What the medical schools are looking to do though, and this is an interesting little side conversation, but so the medical schools are looking to create sort of residency ready students. So it's students who are ready to come out of medical school and they've matched a series of competencies that we know program directors want their trainees to have. So can we show them that in their medical school training they're getting these things done so that when they hit their residency program they already have a certain amount of knowledge of being able to do things.
Are there different accrediting bodies for the medical school versus the residency programs?
Yeah. Yeah, the medical school accreditation body is different than the ACGME.
And is the
But there's-
ACGME, is that connected to the actual, like, how you actually become a doctor?
Yeah, so
The approving body that
they're the approving bodies for people to become practicing physicians.
similar to ordination versus like a degree from a theological institution.
Right. The American Academy of Medical Colleges, the AAMC, is the one that is in charge of the medical schools, and the ACGME is in charge of the residency training programs.
Are there any ways of knowing if a physician is going to be better in a large setting or a small setting? Or does all this apply no matter whether they're in a big institutional hospital or a small clinic?
Yeah, so I think you could argue that there are people who are going to thrive in busy environments and there are people who are going to wither in busy environments. And we've had people like that in our training programs who will be great in a small community hospital where it's not so busy and the patients aren't as sick as they are in a university hospital, but they just can't cut it at university hospital. So where would they fall off? Probably on the patient care. Probably if you start looking at some of the things on here about obtaining accurate histories or being able to synthesize multiple data in any variety of diagnosis. So your community hospital and someone comes in with a pneumonia, great, you can take care of the pneumonia. But when you're in an academic hospital, they've got a pneumonia and they've got HIV and ulcerative colitis and they've got one working kidney and liver failure. And so they've got that on top of the pneumonia. So.
You never direct them where to go, do you? Do you say, you know, buddy, you need to be in a clinic or you need to be in a...
Yeah, you do. Yeah, you do. So a lot of times when people interview to go to a residency program, they'll take that into account. So if they know themselves a little bit and they say, you know what, I'm not cut out for the crazy busy stuff, I'm going to apply to a less busy community-based program, they'll kind of self-select them out into that. There are those people who we have in our programs who that is the case. They just need to get through it. They're not bad people, they're not bad doctors, but the pace is too much for them. You've talked with them, and your advisor has talked with them, and the program director has talked to them, and said, "Listen, your probably best bet is to go into something like this." So yeah, you do counsel people for that.
Could you maybe talk about some of the dynamics or characteristics that exist between, and maybe I'm just being ignorant about this, but like a hospital versus a training hospital? Because one of the ways, an angle on the conversation we're having, those churches that are, looking to launch and sustain residency programs, there would be a shift in what it would mean to be just a local church serving, a community versus a training church that says an aspect of our identity as a local church is actually helping to produce more leaders for our church or others. So I'm just wondering if you can help see the analogy.
From a perception of the public or a perception of the patients?
Internally within the hospital, like what's the difference in leading and managing a hospital versus leading and managing a training hospital?
Yeah. So there's a patient's level like I'm more patient to you because it's more difficult to work with you, that type of thing. In that it's harder for the nursing staff to work sometimes with trainees. Sometimes they just want to go right to the attending or right to the more senior resident. But the better senior resident, when they get asked a question, will turn to their intern and say, "What do you want to do?" So there is a little bit of a inefficiency that's built in to allow people to get those skills they need to do it. The community and the patients that we serve, know it's a teaching hospital when they come in there. They realize that they're going to be seen by a medical student, a third-year medical student, a fourth-year medical student, the intern, the resident, the attending, and probably the fellow of that team, and then be seen by the similar cohort from the specialist team that's being consulted on them. So there's lots of people that they're seeing. I think that there is a shift in the way people view that. Some people don't like that and they find that frustrating. Other people look at that and say, there are a lot of eyes on me right now, and the more eyes that I have on me, the more time is being spent with me, the better care I'm going to get. So there's a little bit of that perspective that changes in the patient's point of view. From a administration point of view, yeah, there are more inefficiencies at the front end of residency training, but when you train them well, they're far more efficient and cost-effective than hiring an advanced practitioner nurse or another attending to do that work, because A, they're paid less than the other people would be, but they're in it every single day, and that's all they do, and they're very good at what they do. So there's a little bit of a learning curve. So there's that July, August, learning curve at the beginning, but by the time they hit October, November, they got it. Did I answer that question?
Yeah.
Okay.
Can you speak to attrition rate in med school? Like, are you trying to weed them out, or trying to get so many of them to quit?
Not in med school. So the med school is pretty adamant on making sure that their residents will that they graduate. The old joke of what do they call the person who finishes last in their medical school? Doctor, yeah. Right. So, yeah, so the medical school does a good job of trying to help that. In residency program, we really do as well. I mean, if we owe it to that trainee who comes to work with us that we're going to train them to be a physician. If, though, they are not meeting the standards, and they're consistently not meeting the standards, we have let residents go. So there is, boy, let me think what this is. I'd say probably 5% that on any given year would be either let go or are put on probation or disciplinary action because of not meeting competency milestones. Any other question?
I can see with both of these fields, there's this kind of internal personal character element. So if on some of these ratings, they're just getting consistently low scores for those kinds of areas, do you provide other resources to bring them on?
Yeah, so that's something we call academic probation. We put someone on academic probation. So if someone's not meeting that, if they're not meeting those milestones, you figure out which area it is. So medical knowledge is always the easiest one, because medical knowledge is you put them on a study program and you make them read a certain amount of stuff, and that's pretty simple. Where it gets tricky is when it comes to the interpersonal communication things or the professionalism stuff. And if someone's really not a professional and they demonstrate bad professional behavior, it's hard to necessarily teach them that. Either they're a good person or they're not, I think, sometimes. So there are some things that you can show them. They can do standardized patients, simulation labs, and then you can watch them with the video, show them what they're doing, show them how they could have done things differently. Direct observation with you in the room. That tends to be a little forced feeling when you're doing that, but it's still a way to look for bad behaviors. But there are ways you can find an area, put together a study plan, and then say, if you haven't reached this level of training by the end of the study plan, you might be dismissed. And so there is an incentive for them to do that.
For the standard kind of sort of MD person, what does ongoing training look like post-residency?
So we have what's called maintenance and certification. So we have to fulfill a certain amount of CME, continuing medical education credits each year. So that could be lectures, that could be completing workbooks, study guides, those type of things. And then every 10 years we have to retake our boards.
Is that continuing education tied to these competencies yet?
No.
Might be a silly question. Do they get paid to do this job?
For residency? Yeah, we say it's not the worst job in the world, it's just the worst civilian job in the world. Yeah, yeah, they get paid, the resident salary is somewhere in the 40s per year, and they work 80 hours a week. So they have busy work schedules, they're there a lot. Back in the day, we worked over 100 hours a week, and then the duty hours came in. Now they can only work up to 80 hours a week, so. Weaker, that's what's going on. No, but it's a little more humane in how they do things. But yeah, so they're essentially cheap labor, like I was saying initially. But the learning curve of that, and could they be better served by other people in the hospital? Residents are still the most efficient and best labor force within a teaching hospital.
Can I ask another question? How does that work, like, legally, is that still within the, like, hourly rates? You guys break it down by that, or are you?
We don't really, they're salaried, yeah.
Yeah, so it's under.
It's like $7 an hour is what it comes down to.
Yeah, yeah,
Yeah.
okay. And then my other question was just the monthly, I mean, 36 evaluations is a lot.
Mhm.
And I know we kind of talked about it, but is it an hour long? Is there a conversation with them, or they just get the paper handed to them? How do
With the
you-
advisor? Oh, so
So not the 2-year evaluations, but these monthly things, how do they get the information presented?
So twice a year we meet with our academic advisees, and we have a form that we complete with them to go through how they're doing professionally, how they're doing personally, how they're growing as a physician. But we review the evaluations from those clinical competencies meetings with them. So we say, here's what your score is right now, here's how you're doing.
So they only see this stuff twice a year?
Yeah, but they have access to the files whenever they want.
Okay, but people are filling them out on them monthly?
Yeah.
They only talk about it twice a year?
No, so that's a good point. So residents see their evaluations as soon as the attendings fill them out. Attendings will see their evaluations after 6 months of aggregate data, so you can't figure out who filled that evaluation out on them for fear of retaliation or reprisal. So if you filled something out on a trainee, they would know that you filled it out today.
Okay. But they get a conversation about it at 6 months and 12
Yeah.
months? Okay.
It's just a curiosity question, so you can answer quickly and move on. Is that with the growing rates of DO programs, things like that, do they have the same mandates
Yeah.
and the same oversight as MD?
Yeah, so an MD and a DO, and the DOs come out and join an ACGME accredited residency program, they have to follow all the rules of the ACGME.
Okay, so that really the only difference is just in the medical school.
Right.
So, like when someone's on the surgeon track, they have specific milestones, but then there's other milestones that are general for any residency, so some are specialized and some are.
Correct. Okay. I have a bunch of other ones that I was going to go through. I was going to go through some things with teaching and how you want to train your faculty or train the people who are going to be doing evaluations, but we're not going to do that. So I just wanted to go to kind of the last couple slides here. Feedback stuff. Yeah, I like that one.
Can we see those?
Okay. How do you know when you're doing a good job?
That relates to church very strongly.
When you don't come into office, I must be doing a good job. I must be doing okay because there haven't been any speeches about patient safety lately. I must be doing okay because you always tell me when I make too many errors. When you don't send my reports back, I know I'm doing a good job. When you don't look at me and shake your head, I know I'm doing a good job. Yeah, I did a little about feedback because this. So honestly, teaching and feedback, I'll talk to you about in a second here. I knew I was going to not go through too many things. Real quick on teaching and feedback. You got to train your teachers, and that's just, I'll do it real quick on this, but you got to train your teachers. So making sure your teachers are prepared to teach, understand adult learning theory, and have a variety of tools that they have available to them. Sometimes it's observation, sometimes it's being fly on the wall, sometimes it's shadowing, sometimes it's mentoring. But there's lots of different ways that people do teaching when they're in medical education. That's kind of what I talk about here. And then maintenance, refining that teaching periodically and getting feedback from your learners about what worked, what didn't work is an important thing to do. Feedback, the rule with feedback, just to kind of put it out there, because if you're going to be doing trainees, you're going to have to learn how to give feedback. Has everyone heard like the feedback sandwich? So the feedback sandwich I think is so overplayed because what that is you say something good, you say something bad, and you say something good, essentially. You end it on a positive note. And, the problem with that is it's gotten to the point where everyone knows that as soon as you say something good, there's a but coming in there. And then you know they're going to put like that feel-good thing at the back end. So it feels kind of contrived at this point. So the biggest thing with feedback is it has to be specific. You did a really bad job on that patient, you dressed pretty well, and you're not a very good doctor. That doesn't help at all. So being specific, when you met with that patient, I liked how you got the initial history and physical. You cut them off. They were just about to say some more about what was going on with them. So maybe if next time, let them talk a little bit longer. Let them finish what they were going to say, because I'm pretty convinced that if you let people talk, eventually they will tell you what's wrong with them. But you have to listen long enough for that to happen. So that's a good, bad, good type thing that you can give someone when it comes to feedback. But be very specific with your feedback. Teach first and be focused. For those people who receive feedback, it's not an assault on them. It is just one data point. So they need to learn that this is not a statement of their character. And when it comes to asking for feedback, it has to be, you want to ask for specificity, and you have to make time for it. It can't be on the fly. It has to be, you're actually making time to actually go through feedback with them. But what I want to talk a little bit about was with the milestones, some of the lessons learned on it. So if you're going to develop your milestones, start with knowing where you want to go. So that was our competencies. We knew we wanted people to have medical knowledge and interpersonal communication and professionalism. And then you have to work backwards to figure out when they can get there, and then you create specific mile markers along the way to tell you how close someone has gotten to getting to that point or not. The milestones have to be specific, they have to be reproducible, and they have to be achievable. They actually, they can't be so far off to the right that no one's ever going to get to that level. They have to be levels that a good practicing physician or whomever is going to be able to achieve. You're going to have to train the trainers, like was brought up over here a little bit, in helping people understand what the milestones are if you're going to develop them and how they're supposed to grade with them. They're going to have to understand how to teach and how to reevaluate that tool if it's not working. That's what the ACGME is doing right now. They're kind of reevaluating the tool a little bit. Maybe it needs to be altered a little bit, but I still think it's heading in the right direction. Competency committees are nice though, so they do allow you to bounce things off of each other. So if you guys are having this, maybe partnering with other parishes so that you have multiple people who could work together and then coming together periodically and go through the assessments, more data points are good.
How do you control for bias in the committee? I mean, a lot of these things that help you figure out if they're doing it well or not, it's a gut thing, and that's very similar to us. It's not, I mean, if there's a very clear error, then that's one thing. But a lot of times I don't think they're quite there. And you'll develop bias, and you'll have these. How does a committee deal with bias?
So I think what we've found is, you're right, that gut feeling of whether or not someone's progressing or not has always been there, and that gut feeling translates really well to that spider web now. So you see that there's divots in there, or they're not progressing like they should be progressing, and it really quantifies it. So you really do see it now. So it's sort of,
Lean on the data.
you lean on the data, and it's less of a personal assault when you talk to the person about it as well. So it does show them where you're concerned about it. It makes that feedback more focused.
Also, we'll go back to that feedback triangle.
Sure. Am I messing up schedules at all?
You got about 5 minutes.
5 minutes, okay. So there's 3 aspects of feedback that I think are important in this one. There's the person who's giving the feedback, the person who's receiving the feedback, and the person who's soliciting the feedback. And on the side are what happens if you're not ready for that feedback or if it's not right. So in this first one, if you're giving the feedback and the person's receiving the feedback but they didn't ask for it, I really expect if you come to the conference, wearing a tie, it'd be nice to have you wear a tie too. So he's like, shut up. That's what he's thinking. Maybe because it's religious-based, you're not thinking that. But that's what you're thinking. You didn't ask for that feedback. There was no reason that came up. So it wasn't a useful thing. It was lip service, and you're coming like, okay, fine, I'll wear a tie next time. Move on. And everyone was saying, thank God he didn't address me because I'm not wearing a tie. So that wasn't useful. If someone gives feedback but they didn't solicit the feedback, where is that an example of? You're trying to throw some feedback at somebody and they've just gotten off of a busy shift and not really listening for it. They're not ready for it, so it bounces right off and they didn't really receive it. It wasn't the right time to give the feedback. And this last one, if they're asking for feedback but you're not giving the feedback, they feel very demotivated. They feel like they weren't important and that they weren't worth your time to sit and talk with them about how they get better. And that happens all the time in busy rotations. You look up and 2 weeks have gone by and you said, oh, we didn't do evaluations, or we didn't do feedback. So you have to make time to do it. And if you don't do it, the students are kind of like, I thought we were going to sit and talk about how I was doing. So.